Hello everyone. In this series of clinical cases, today we will discuss a case of high calcium. In the clinical history, patient is a known case of type 2 diabetes for last 10 years. Patient presented to our OPD with the presenting complaints of osmotic symptoms, dizziness, weight loss, and she is taking metformin 500 milligram twice a day. On examination, weight is 36.8 kgs, BP 120 by 60, tachycardia is present, dehydration was there. Other systemic examinations were normal. When we did the investigations, so she presented to us in mid May, and the creatinine value, as you can see here, was 2.03, and HbA1c was 8.9. Uncontrolled sugars with high creatinine level. In the management, we immediately stopped metformin because metformin she was taking 500 milligram twice a day with a creatinine of 2, so it has to be stopped. And we started medicine linagliptin, which is safe in renal failure, and we advise for a repeat kidney function test and urine protein creatinine ratio in view of ki she might be having a diabetes nephropathy. Repeat KFT creatinine came out to be 1.80, and urine protein creatinine ratio was 0.50, which is on a higher side. So the total calcium came out to be 13.33, which is high. So she was having high calcium and renal failure. So whenever a patient presented to us with high calcium, the most important next investigation will be the PTH level. Because if the PTH level is high, this is a case of primary hyperparathyroidism. Other causes of high calcium like excess of vitamin D from endogenous sources like some granulomatous disease, sarcoidosis or tuberculosis, or exogenous intake is high. Malignancies like multiple myeloma or any metastasis, bone resorption due to immobilization, drugs like thiazide or vitamin A. All of these leads to high calcium, and that high calcium then suppresses the PTH level. So PTH level will be low in all these conditions. While in primary hyperparathyroidism, PTH level will be on a higher side. So the next investigation that we did was the PTH level, and you can see here PTH level came out to be 4.40, which is low. So it means patient might be having these condition which is responsible for high calcium with a low PTH value. So we asked the history for exogenous vitamin D intake. So she was not taking any exogenous vitamin D. We also suspect there could be a malignancy or there could be some granulomatous disease like sarcoidosis or tuberculosis. She was losing weight. So we get the vitamin D levels done, and vitamin D level came out to be more than 350. So out of those causes of vitamin D was high, she was not taking exogenous, so could be endogenous vitamin D production was more. And we also did the multiple myeloma test, M spike we did because proteins were slightly on a higher side in the investigation, but there was no M spike. Coming back to this flow chart again, patient has high calcium, vitamin D levels were high. So our main suspected condition was granulomatous disease, sarcoidosis or tuberculosis. So to know sarcoidosis or tuberculosis appropriately, the next step should be a chest X-ray. Chest X-ray was normal, but chest X-ray can be normal in sarcoidosis or in tuberculosis. So what we did, we get the ACE levels done. So ACE level came out to be high. So ACE levels are high in any granulomatous disease like sarcoidosis also, tuberculosis also. Next step was कि we planned for a CCT chest, but CCT chest was not done in this patient because of the deranged KFT. So we take a opinion from a chest specialist, and he advised for bronchoalveolar lavage fluid analysis. So bronchoalveolar lavage fluid analysis was done, and the report came out to be positive for Mycobacterium tuberculosis. Now the picture was clear. Patient has tuberculosis because of which patient has lost weight, and patient has high vitamin D level because of granulomatous disease, and that has caused the high calcium level. So maybe high calcium level can lead to renal failure. That is a possibility. So the patient was managed? Patient was started on the ATT. As you can see, this is a prescription of the patient. ATT was started, and you can see number 5 medication, Medrol. Medrol is steroid. So why the steroid was started in this condition? The reason for starting the steroid is steroid inhibit the vitamin D synthesis. So when vitamin D synthesis is reduced, automatically calcium level will automatically become normalized, and that might lead to improvement in the creatinine level. So this is how we managed a patient of high calcium, which was responsible for nephropathy or kidney disease. So if you have such cases, or you have experienced such high calcium level, you can write down in the comment box. Any queries, any suggestion, you can also write. Thank you.